I'm kidding. Okay, this is from the neonatal resuscitation course from the American Heart Association. It's an algorithm that they created as far as how to manage a newborn, and I believe I have this blown up for you in the back section. So let's kind of go through this piece by piece. There's really three questions because the second one they dropped, but was the baby born at term? If the baby can survive to term or near term, the chances they'll need resuscitation are dramatically lower. Okay, and like I say, 90% of the babies are uncomplicated, so it's no big issue. Preterm babies obviously are higher risk. The more preterm, the bigger the risk. Is the baby breathing or crying? Gasping is not crying. Okay, so if the baby's not crying, that's a bad sign. They're probably going to need to have some resuscitation done. Is there good muscle tone? Babies should have the ability to have muscle tone that is, I'm going to say more than present, but if you see a child who is born and they're just a flop lying there, chances are that's not going to be a good resuscitative effort. I got some pictures, I believe, in here. So there's a good-looking little kiddo.
Any baby who's pissed is healthy.
That's a good way of putting it, yeah. You could take it from this nice, warm, wet environment where it's all quiet and peaceful and brought out to the light. And, oh, good Lord. So if the answer to those questions are all yes, then the baby does not need to be resuscitated, and you basically keep it with mom. They dry them, put skin to skin with mother, and cover with dry linen, and then just basically do an assessment of the child as far as that is concerned. So the first minute is really the important component of all of this. That's where we're going to do our initial assessment. So there's our three questions: term gestation, breathing or crying, good tone. The answer to those are all yes, they stay with mom. Provide warmth, clear the airway, dry, and basically do additional evaluation. If those three questions are not all yes, if one or more of them is no, first thing we're going to do is warm and clear the airway, dry them, and stimulate them. The four things we talked about last time. Okay? We then do some assessment. The first thing we assess is the heart rate. If the heart rate is below 100, or if they're gasping, or if they're apneic, we're going to do some other interventions. If not, we're basically going to ask, is the breathing that is there labored, and is there persistent sign of cyanosis? If yes, we're going to do some other oxygenation interventions. If not, we'll just go back to that routine care. Respirations, again, a strong crying, strong quiet ventilation, those are considered what would be normal, adequate depth and rate. If anytime you have some apneic episodes that are prolonged, gasping attempts, they may need to have positive pressure ventilation done. We'll talk a little bit about how we accomplish that in a few secs. Assessment of the heart rate should be done either by auscultating. You can also palpate the umbilical cord to be able to assess it. And you can also use pulse oximetry, but certainly don't delay assessment trying to wait for to get the pulse oximeter hooked up and functioning. In utero, remember, we were talking about having a PaO2 prior to birth dramatically different from what they're having in the post-uterine world. Even babies that are born that are uncompromised, that are born in a normal state, still have saturations that are in the mid-70s. It's not uncommon to have an oxygen deficit initially, but certainly by the first 10 minutes of birth, you're basically able to get that cardiovascular, cardiopulmonary system functioning to where they're ending up being in a normalized state. This is why skin color is not really the best of assessments to end up using. because it can be tricky, okay? Preductal oximetry levels are what we're going to look for. So preductal would be where? Right arm, right side of the upper chest, right side of the head. Okay. If spontaneous ventilations are adequate, saturations are low, you can consider using CPAP, and we'll talk more about CPAP another day. So this is what we're kind of targeting as far as our preductal SpO2s after birth. And you can see that it's not until you're getting at near 10 minutes that we're back to a normalized level. So it's okay to be a little bit on the dusky side. And I'll show you some pictures of some children that are well beyond that. You can see how profoundly hypoxemic they are.
So a test question might be, within X minutes, quote unquote, normal SpO2 would be reached by newborn, blah, blah, blah.
Yeah, by 10 minutes. I don't expect you to memorize that chart. Okay. Yes, Dana.
Wait, so we were, like, I think it was last semester, you were taught that the whole entire head is preductal.
Now, actually, the left is variable. The left side is variable.
Okay.
Because it really depends where the ductus is in relationship to the left common carotid and the left subclavian.
Because Mary said that you can always use the right or left earlobe. She said that you could always do it.
Okay. I would
So, I
prefer
mean,
I would
don't
prefer
know.
we stay with the right.
Okay.
Okay.
Is that the same thing for the chest as well?
More so
Chest.
for the chest, yeah.
Okay.
Left chest, I would definitely put as being either variable or postductal. All right. So we said that color is not a real sensitive indicator, but we are going to talk about color being the baby being cyanotic. You think the top baby cyanotic? And that's called central cyanosis, okay? The bottom one, it's just the peripheral limbs that are cyanotic. That's called acrocyanosis. Acrocyanosis is less of an issue than the central cyanosis. The baby on top is in profoundly more trouble than the baby on the bottom, okay? And you may end up getting some of that is perfusion dependent, some of it is just poor oxygenation. If they're pink, whether they have acrocyanosis or not, we're just going to observe and monitor them. If it becomes persistent central cyanosis as the top baby is, we would need to do something to improve oxygenation. There is something called the Apgar score, which I think you're all familiar with. Apgar is actually the person's name, Virginia Apgar. She was a obstetrician who basically came up with a scoring system to be able to derive how well the baby is progressing as time is going on. We measure this typically at 1 minute and at 5 minutes, and you can continue to do it for as long as you need to. Now, the elements being evaluated are the 5 listed there: skin color, heart rate, reflex irritability, muscle tone, and respiratory effort. Now, they have modified them so they spell Apgar. Isn't that just nice? But appearance is skin color, pulse is heart rate, grimace is reflex irritability, where we actually will go ahead and place a suction catheter in the baby's nose, and when you suction the nose, does the baby become irritable? Muscle tone, as far as how limp or active they are, and in a respiratory effort would be the respiratory rate that we would use. So here's how the scoring goes. You can see the heart rate. The Apgar is scored 0, 1, and 2. 0 is pretty much absence of something, or in the case of color, being blue all over. 2 is the exact opposite, and 1 is kind of in the middle. And what you just basically do is score based upon the heart rate, based upon the respiratory effort, their color, their muscle tone, their reflex irritability, add them all up, and if they're 7 to 10, they're ducky. We monitor them. We might need to do some oxygen if their peripheral cyanosis doesn't resolve, but we basically just do normal care with them. 4 to 6 is that intermediate range where we're going to need to be involved typically just with bag valve mask ventilation. That's what BVM stands for. So we're basically using a resuscitation bag and a mask to be able to support ventilations. 0 to 3, this is where we're basically be going full bore interventions. So I would feel comfortable giving you a scenario and having you tell me what the Apgar score is, and or beyond that, what kind of involvement would be needed on the part of the resuscitation team. Cool? Sucks to be you. I'm gonna. You won't have the chart, no. I will give you a scenario. You have a baby whose heart rate is 80, their respiratory effort is absent, their color is pale or blue extremities, their muscle tone is weak passive tone, and there is no reflex irritability.
Let me to remember which points, how many points are for each.
Yeah,
Okay.
yeah. Because you're going to have to total it up.
Okay.
I mean, it's pretty straightforward.
Mm-hmm.
If you know 0 and 2, 1's kind of in the middle. What a novel idea. Virginia was nice.
Question.
Yeah.
The book says start CPR if the heart rate falls under 60.
Right.
Why would they not say less than 60 for 0 points there? Heart rate.
That's just the way it scores.
If you wait till it's 0, then
Yes, we know.
it's pointless to do it.
Well, it's not pointless. It just got me. That's just the way the scoring goes.
So if you were to say on like for one of those scenarios, if you were to say that the heart rate is, would you say the heart rate is less than 100, or would you give us an?
Oh, I would give you a value.
Okay.
Yeah.
Okay.
If you look at them, 3 of those criterion are really dependent upon maturity of the baby. So the longer the gestation, the chances are better that the muscle tone and respiratory effort and reflex irritability is going to be higher. Those babies born prematurely typically are neurologically underdeveloped, as well as respiratory system underdeveloped. So you probably will, those 3 are quite key. Of the 5, heart rate is probably the best to look at, and color being least important, but it's all subjective to some extent. Chances are it's one way or the other.
Very low birth weight, that's what we're talking about.
Yeah, very low birth weights are the ones that end up having the level of maturity being drastically reduced. Yeah, that's kind of you can see the limp, muscle tone, no crying. That's dramatically premature. So what we need to do then is look at oxygenating this child, ventilating this child, perhaps doing external chest compressions, and medications. Those are the 4 components of resuscitation of a newborn. So let's talk about oxygen first. There's a real big debate amongst people whether or not you treat them with 100% oxygen. And more, I think you're seeing people say, you know what, they don't need 100% oxygen. Because in utero, they don't have, they're surviving with a lower PO2. They can acclimate to it. So right now, the guidelines suggest using whatever it takes to get the pulse oximetry where you need to get it, which is kind of a cop-out, but makes sense. Yes, Liz? Well, that's the question. In a lot of cases, a lot of places will advocate using room air. Some places still use 100% oxygen. Some places split the difference and start at 50. I don't have a good answer for that, other than it's not mandated. In adult resuscitation, it's always 100% oxygen. Here, not so much.
Well, as your cases of oxygen toxicity.
Well, that's part of the fear, as we'll find. 100% oxygen, driving the PaO2 up too high,
Too fast.
or too fast, can lead to a whole lot of problems, one of which is blindness.
Yeah,
So,
so if there's problems, historically, has there been problems with that?
yeah. Oh, yeah.
So what about this technique of using 100% but holding it?
Hold that thought.
Distance of-
Are we there yet?
I don't know.
We're not.
Well, it's a concern.
Did you have a question, Jess? Okay. So trying to get the pulse oximetry up, and also considering the use of CPAP, these babies, especially the low birth weight ones, are born with an FRC that is not fully established. So using CPAP may help that, but again, the jury's kind of out for sure which way we go in the initial resuscitation period. Positive pressure ventilation is present whenever you have apneic episodes that are prolonged, or gasping that is not correcting itself when you stimulate the baby, or if the heart rate is less than 100. We're going to go ahead and initiate positive pressure ventilations. Kind of odd to think that because my heart rate's low, I'm going to ventilate them, but usually the heart rate is low simply because they don't have enough oxygen. So providing the ventilation will end up improving that process. So there's my positive pressure ventilation. If my heart rate's below 100, I take the ventilation corrective steps, which is to begin external chest, to begin bag valve mask ventilation. If no improvement in heart rate after I start, then I'm going to go and do some additional stuff. What I'm looking for here is to assess basically the chest wall displacement. So when I'm ventilating, I'm looking to see the lungs inflate and deflate. It's a very rudimentary way of ventilating. Positive pressure, usually 20 centimeters of water is sufficient, although you may need higher levels of positive pressure, especially in the premature child who doesn't have a well-established FRC yet. If the chest isn't expanding, we need to first make sure the airway is opened by properly positioning the airway, making sure that we're not hyperextending the neck, that it's in a neutral position. Make sure that there's not something else that's obstructing the airway, or that we don't have a pneumothorax evaluating breath sounds for bilateral presence. Respiratory rate of 40 to 60 is typically sufficient, so that's our target rate, and we're just trying to get that heart rate back up above 100. Mask. The mask is important to cover both the eyes. Cover the mouth and nose, but not cover the eyes or any of the overlapping chin. Also need to be careful that you're not pressing the child's neck and compressing the trachea when you're holding the mask in place, as this one on the left shows, is a proper technique of pulling the mandible back, but not compressing any of the soft tissue below that point. Masks are always clear, obviously, and they have some sort of a cushion to allow for the mask to be applied gently on the child's face.
So going back to like the target rate of 40 to 60, is that at least like how much we want to give them?
Yes.
Okay.
When we would ventilate them, we would squeeze the bag once every second or something in that general area. 3 types of bags that are present. The most common one that is in use is what's called the self-inflating bag. That basically, as the name implies, as you squeeze it, when you release it, it self-inflates back up again. It fills itself back up with fresh gas. So it does not require supplementary gas flow, so if you don't want to have oxygen running to it, if you just want to bag them with room air, certainly possible. If you want to have 100% oxygen being delivered, there needs to be a reservoir, which would be basically some tubing that extends out the back. And then when I'm running my flow of oxygen into this device, not only is it filling up the bag, but it's also filling up this reservoir that's behind it. Then when you squeeze the bag and release it, it draws from that reservoir when it's refilling. So it's basically driving the FiO2 or the FDO2 up to a higher level. The volume of these things are somewhere on the order of 450 to 750, which means you don't need to squeeze the whole thing. Just a small amount of squeezing on this will generate a tidal volume that's going to be effective. There is a pressure monitoring capability. That's what this blue port on the side here. I can hook this up to a pressure manometer and monitor the amount of pressure I'm using, trying to target that 20 centimeters of water. And there also is a pressure release valve, which typically is activated at 35 centimeters of water. So if I need to go higher than that value, I'm going to need to override that pressure pop-off in the process. So that's the self-inflating bag. Again, probably one of the more common ones that I end up using. Some people, on the other hand, prefer to use what is called a Jackson-Reese or Mapleson F circuit. This is a system that has a collapsible anesthesia-style bag that only is inflated if gas flow is going to it. There's no gas flow going to it, it stays deflated. Okay, it's like a balloon. So I hook up my gas source here, and there's a little control valve that controls how much gas is going into this bag. Needs to have a clinician who understands how this works, which is why we don't see it used a lot, because it is a little bit trickier. I have to adjust the flow so there's enough flow to keep the bag inflated, but not so much flow that it's creating extra pressure within the circuitry, which could be harmful to the baby. Okay, so there's an adjustment of that flow valve to get just enough, but not too much. Have to have a seal. This is hooked up to an endotracheal tube. There's certainly no reason you couldn't have it hooked up to a mask. And again, it requires that therapist who's ever doing a resuscitation to be very cognizant of how much flow is going into that bag. And then finally, there is what is called a T-piece resuscitator, or NeoFlow. And this basically is hooked up to a 50 psi oxygen source. You dial in a concentration of oxygen, and basically on the mask itself is a small little valving mechanism that as you press it down, it goes ahead and allows gas flow to go through the mask into the child. You release it and it shuts it off. Okay? And that's just called a NeoFlow or a T-piece resuscitator. Which one you choose depends upon where you work, but I'll be honest, probably the majority of the places use the self-inflating bag. It's the easiest to operate. And in Walsh, this table goes through the advantages and disadvantages for each of the three devices. And it really depends on, to some extent, experience of the individual. Yeah. Why might you select one example over another? I don't know if I blew this up in the back for you. Did I? Was that it? Did I just pass it?
No, that wasn't it.
Not on the left?
Not this one.
It's in the book, page 42. If bag valve mask ventilation is not effective, that would be an indication for an artificial airway to be placed. Also, we'll need it if we're going to doing ventilation for any prolonged length of time, say a child that has respiratory distress syndrome. If thick meconium is present in the amniotic fluid, we will need to intubate. And there's also some other disease states we'll find, like congenital diaphragmatic hernia, that we have to intubate also. And whenever we're doing chest compressions, we're going to intubate those children. Obviously, it's a skill set that you need to be good at and maintained. And we know that the equipment that is required has to be functional, obviously. And I talked about congenital diaphragmatic hernia. You can't ventilate those children until you have them intubated. And when we come across that disease, it'll be obvious why that is the case. This is another one that you'll need to know as far as the size of the airway itself. The endotracheal tubes are in half sizes, the smallest being 2.5 internal diameter in millimeters. And those are reserved for the infants that are less than 1,000 grams or less than 28 weeks, which typically those two things go together. You rarely are going to see a child that's less than 28 weeks that's 1,400 grams. It just doesn't work that way. A 3.0 is between 1 and 2 grams in 28 to 34 weeks. 3.5 between 2 and 3 grams, 34 to 38 weeks, and greater than 4, or a 4 would be used on any baby that's greater than 3,000 grams. In pediatrics, there's a whole separate set of rules that are there too, but we'll let that go for now. Okay. So this is an important thing that you may want to pay attention to. Hint, hint, hint. Laryngoscope only have Miller blades. There is no Macintosh blades in the neonatal world. They're all straight blades, and that's because that vallecula is not really well defined, and the epiglottis is far more floppy than it is in the adult. The larynx is also more superior, and the epiglottis more horizontal, so it really makes it easy to lift it with a straight blade. Stylets, which again allow for the tube to become a little bit stiff so it doesn't get floppy. We start with the blade on the right side of the mouth and sweep the tongue to the left. Visualize the larynx, verify that the glottic opening is visualized, and go ahead and put it in place. Here you can end up seeing the epiglottis up on top, that poorly defined vallecula and the true and false vocal cords, and the glottic opening that you want to push the endotracheal tube through. You can see there's not a lot of distance between it and the esophagus. I mean, there's not a lot of room in some of these kids, especially as you get smaller and smaller. Once we have the tube placed, we're going to auscultate. We'll also visualize and use end-tidal CO2. It's important because some of these children, for one, they're so small that you actually need a neonatal stethoscope, not a conventional stethoscope. A neonatal stethoscope has a bell and a diaphragm that are dramatically smaller than the other ones, because the kids, you put my stethoscope on their chest, and it's basically their whole body is being covered. So you need to have something that's a little bit more directed towards their size. Also, because their chest wall is so thin, you can hear bowel sounds through the chest. Let me rephrase that. Sounds are transmitted across real easily. So even though you may be in the right main stem bronchus, you may hear sounds on the left that are transmitted. So auscultation's not the best. It's a start. Visualization of the rise and fall on both sides, because their chest walls are so small, it's easy to ascertain that. But again, end-tidal CO2 is the gold standard that we're going to use to be able to monitor that. Mary talked about end-tidal CO2, didn't she? Or was that last semester? Last semester. Jeannie and Ray. You'll need to have the chest x-ray done to verify depth of placement. Basically, you're trying to get it somewhere between the carina and the clavicles on a chest x-ray. What we're going to use is the formula here. The weight in kilograms plus 6 will tell us where the insertion depth should be at the lip. So in other words, the distance from that point to the tip is dependent upon the child's size. So if you're less than a kilogram using the 2.5, it's going to be that 2.5 plus 6. No, I'm sorry, the weight plus 6 to determine where you're at. Okay? That kind of gives you the gist. So not only do you need to know what size tube you would need to know how far in that tube should be placed. Because until you can get a chest x-ray, we're ventilating this child. You don't want to be ventilating one lung. So as Andrew was saying, we're going to go chest compressions. Heart rate's less than 60, we're going to immediately go to that point in time. We use the lower third of the sternum. We compress basically a third of the distance of the AP diameter of the chest. There's two techniques that are utilized, a two-finger technique or a thumb technique. The thumb is one that is actually recommended. It's a little more effective being able to do it. You can circle the child's chest with your two hands and use your two thumbs to compress the sternum. Yeah, we're going to go ahead and do one breath every 3 compressions. I believe that's still right. Roughly as many as you can end up doing. Closer to 100, better off you are. So again, heart rate below 60, we're going to intubate them, begin compressions. If the heart rate doesn't, if the heart rate improves, we're going to reevaluate it and ventilate as necessary. And we'll talk about epinephrine in a bit. Oh, let's talk about it now then. The two primary ones that we're going to end up using, epinephrine. Epinephrine is a drug which, as you remember, is an alpha, beta 1, beta 2. So we're using it primarily for its alpha properties to stimulate, to improve aortic pressures, to improve perfusion to the brain and to the heart. Know it. I'm not going to test you on the dosages, which is 0.1 to 0.3 milligrams per kilogram. But just know that epinephrine is the primary agent that we're going to use to try to resuscitate them. The other ones that are there are volume expanders. These premature babies are often born volume depleted, so you need to go ahead and give them something like blood or normal saline to improve the volume that is there. The other three drugs that are there, sodium bicarbonate is a drug which, again, we would use to treat profound acidemia. Naloxone hydrochloride, better known as Narcan. Narcan is given to a baby who was born where mom might have had some medication, and the baby is born depressed, not depressed in the sense of wanting to cry, but depressed as far as not responding appropriately. Narcan is also given for any kind of overdose, opiate overdose. And we use it in the adult side also, but I mean, this is one where, a lot of painkillers that mom gets because of labor gets transmitted over the baby, and the baby is born not really responding fine. A little bit of Narcan will reverse that process. And dopamine we've talked about previously, just being a medication which is used to raise blood pressure. For our purposes right now, we'll just stick with the first two for accomplishing that goal, epinephrine and volume expanders. We also will monitor the glucose post-birth because they're often hypoglycemic in the post-delivery. After birth, they're not eating yet, so they're not taking in any food sources. So it's basically a breakdown of existing stores, breaking down of fats to ketones, breaking down those brown fat stores. Bottom line is that you can end up becoming hypoglycemic quite easy. And you can see their normal values is considerably less than what we end up seeing in the adult population, 35 milligrams per deciliter, and 25 for preterms. That's considered to be, anything below that's considered to be hypoglycemic. I think if I had my blood sugar at 35, I would be comatose. And we're going to treat that obviously with just D10NW, which stands for 10% dextrose in water. Improve that. Lastly, I just want to talk about ethical issues. As a general ethical principle, stopping resuscitation is equally as ethical as not starting something. So when we look at things like removing ventilatory support, that is an ethical process if the outcome is not good. In our cases here, we're not going to start resuscitation quite often if the baby is born prior to 23 weeks. Kind of the rough cutoff, or 400 grams, again, a rough cutoff. Have you ever heard the statement that the United States is not the best child infant mortality? You know, that there's other countries that are a whole lot better. Do you know why? They don't count them. If the baby isn't viable, they don't count it as a live birth. It's not factored into the numbers. We are probably the best country as far as resuscitation of children because we go the extra mile for a lot of them. The other countries, they don't even count it as a birth. Interesting. Other anomalies such as ancephaly, lack of a brain. Again, that would be known on ultrasound. Or confirmed instances of trisomy 13 or 18, which is a chromosomal defect that have extremely marginal lifespans. We're talking hours. And obviously supporting the mom and dad to the extent possible. Most of those cases, they've confirmed these on ultrasound and they're well aware that this birth is not a viable child. But it's the premature ones that are tough. Question?
What was that one case where the baby was anencephaly, but they kept her alive for like 2 years?
Yeah, I've seen some of the trisomies kept alive for a longer period of time. I guess you talk about quality of life at that point.
Yeah, like, I don't understand why they would wanna.
Well, that again is the ethical issue there. Who are we keeping them alive for? Mom and dad, or I mean, they don't have any kind of functioning life. When we talk next year, we'll talk about. I just gave a lecture with the second years, but just talking about ethical cases. There's a lot of times the issues are not of the patients. This was actually one of my old students. He had triplets. Unfortunately, only 2 survived, but that was one of the little kids that were there. Let me just stop this.